Ischemic stroke is a stroke that is caused specifically by a lack of blood flow to the brain. And so, what happens as we age, the little blood vessels are actually the most frail in our bodies. And so, they're the most likely to be depleted. That causes small tissue damage, or what we call small vessel ischemic damage to the tissue, including the heart. And that will start to form a clot because the blood needs robust flow in order to prevent it from clotting.
Hello, this is Anthony Effinger. I'm the host of the Think Neuro podcast here at Pacific Neuroscience Institute. And today I'm talking with Jose Morales. He is a vascular and interventional neurologist, which means you're a surgeon. And we are going to talk about a lot of interesting things today, including AI. So let's begin, though. Dr. Morales, tell us about your background. Where are you from? How did you become interested in this field, and where did you train?
So my name is Jose Morales. I was born in Puerto Rico. I was there until 2 years old. We moved to California briefly and then went back.
Huh.
And I lived there till I was 12, eventually moving over to stateside when I was a young teenager and stayed here ever since. Um, I guess my academic training includes going abroad to Imperial College London. And so after my postgraduate training, I came back to the States, did some research at Harvard Medical School, and eventually landed at the University of Chicago for medical school. Um, Stayed on at Chicago, but at Northwestern University for my residency training.
Hmm.
And then capped off my training at UCLA for both vascular neurology and interventional neurology.
Is that a fellowship or
That's a fellowship at
here at
UCLA.
UCLA?
Correct.
How long is that fellowship?
It's 3 years in total for me.
Okay, so you're looking at that was quite a lot of training.
About 7 years
7 years
after medical school.
after medical school.
Yes,
Wow. Okay, and you were at UCLA and you stayed in town.
that's right.
Better weather than Chicago, maybe.
Oh, for sure.
Yeah.
Well, honestly, we didn't have any roots in Chicago, so when I kind of felt like I was closing the chapter in that book in my life, and I
Mm.
was kind of looking for the next thing. And I guess we've been very fortunate to land in a good school district for our kids,
Mm.
um, and in addition to that, Pacific Neuroscience is an institution that has really built a name for itself in LA as a leading neuroscience, clinical neuroscience provider, and they've done fantastic things within the community. Utilizing the Providence Southern California network to deliver cutting edge care to patients in need of neurological diagnosis and treatment.
Providence being a partner and use their facilities and
Correct.
yeah.
Yeah. So we have a practice built out of this building here in Pacific Neuroscience Institute. But in addition to that, we do inpatient hospital work that requires us to service the different Providence hospitals. To get patients who come in through the emergency room with a ruptured aneurysm or stroke. Um, it wouldn't be feasible to do that just from
No,
an
right.
outpatient clinic.
Sure, of course. Of course. So tell me about the kinds of surgeries you do.
Yeah, so I use minimally invasive means of getting into the structures of the brain um, and the spine. And we typically will either puncture through an artery in the wrist or the groin and use a needle to thread in a wire. And over that wire, we're able to assemble larger diameter flexible tubes that gives us access all the way up to the brain in case somebody has a blockage in one of the brain vessels
Mm.
that is causing an ischemic stroke.
Just find that ischemic stroke is a
Stroke that is caused specifically by a lack of blood flow to the brain.
okay.
And so all living tissues and cells require oxygen, at least in mammals, to survive. And so once you deplete the supply of oxygen from a blockage, then that tissue starts to die over minutes. On average, about 2 million neurons die per minute, but
Mm.
some people may lose up to 30 million neurons per
Mm.
minute, depending on how they're able to compensate for that acute blockage.
And what causes a blockage in an ischemic?
Yeah, so there's a variety of mechanisms. Probably the most common for these large vessel occlusions that we typically intervene on are from the heart. And so what happens as we age, the little blood vessels are actually the most frail in our bodies, and so they're the most likely to be depleted of the structural integrity that they need to deliver blood. That causes small tissue damage, or what we
Mm.
call small vessel ischemic damage to the tissue, including the heart. And so that can lead to the heart developing abnormal rhythms, such as atrial fibrillation, which is when one of the chambers of the heart no longer beats in sort of uniform activity and starts to just kind of
Mm,
quiver or fibrillate.
mm. Oh,
And
yeah, good description there. I've never Yeah, thank
and
you.
that will start to form a clot because the blood needs, you know, robust flow in order to prevent it from clotting. And so once that clot forms inside the heart, it can be embolized or, kind of thrown up to any artery in the body. And sometimes that's the brain. And so those arteries, when they get clogged up and those, from a clot that formed from the heart, we could take those clots out and reverse the symptoms that the patients are coming in with. And those are actually the most debilitating strokes. And they're also a leading cause of not only disability, but one of the leading causes of death as well.
I imagine. That is a terrific I've never understood exactly that mechanism. That's a terrific explanation. The heart, it's just the blood's not being mixed enough, kind of.
It's not well,
It's or
it's being mixed too much, if
Oh,
anything,
too
right?
much.
Because it requires just sort of like a stream of blood flow, and
Okay.
whenever the blood starts to stagnate, it starts to mix the products together that forms blood clot.
Oh, like, it kind of emulsifies even or
Exactly,
something. Yeah, I'm
exactly.
looking for the word. Okay, and then that you said embolizes,
Yeah, which is kinda like
means
just throwing up from one location to another.
and then goes into some small place
It can go
or
either to the
big.
arteries feeding your kidney, your liver, your leg, your arm, but most commonly because the brain is such a greedy organ, it's such a vital organ, right?
Yeah,
So, pound for pound, it takes up the most blood supply of any organ in your body.
and that's why we hear so much about brain
Strokes,
strokes.
exactly.
Yeah, okay.
So that's one mechanism,
Yeah.
especially a common mechanism for large vessel occlusion strokes. But there's other mechanisms such as, people developing plaque that usually is caused by high blood
Mm,
pressure, high cholesterol, diabetes. That plaque has, inflammatory qualities, and that inflammation can cause blood clot formation, and that can end up going up to the brain. That can also occur anywhere in the carotid arteries. There's other mechanisms of stroke that are even from within the arteries themselves. So, like, you can have damage done to the artery, either through like neck manipulation that can cause dissections.
oh, I have a friend who had that happen on bumper cars.
Yes. And so those neck dissections can cause disruptions not only in the blood flow, but also aggregation of blood products and form clots. And those can end up going up
Yep.
above and causing a big stroke.
Yeah, so yeah, that's what yeah. Took him 2 years to relearn how to speak.
Yeah. So we can
Yeah.
fix those. We can, go up there, take those clots out. We can put stents over those, you know, torn segments of the blood vessel if we need to. And so our specialty has kind of a wide range of disease states and problems or that we can address through these minimally invasive means that don't require us to drill through the skull or
Yeah.
take off parts of the skull. And so
Which is what
patients,
you would have done years past or
yeah, well, in many cases, say
not
for
at
like
all?
ischemic stroke, there was
Yeah.
never an option to do any surgery. So people were essentially just taking off the skull to let it swell after it had already been totally damaged.
Is everything you just described ischemic stroke, or did we move on from that?
No, we've been stuck on that
Okay.
topic so
What's
far.
the other kind of stroke?
Hemorrhagic stroke. So those are strokes that occur because rupture of a blood vessel.
Okay.
Okay. And there's a
Okay.
variety of ways where that can occur as well.
Okay. So one's a blockage, one's a rupture.
Yeah.
Okay. And you treat all of these by going in through the groin or the wrist and threading.
These flexible tubes called catheters.
How do you navigate and drive to where you need to be?
That's a great question. So we have X-ray guidance. So these are image-guided therapies that we perform. All these devices are equipped with what we call radiopaque markers, meaning they absorb X-rays and come up as a dark pigment on the screen. So you can see exactly where your instruments are in real time, and you can guide them up under image guidance to the location of interest.
You can see the instrument, but can you also see like the paths and the forks?
Yeah, that's correct. So when we use our either when we use fluoroscopy, we can inject contrast through these catheters, and this can light up the blood vessels.
Okay.
And they absorb radiation that causes them to what we call opacify, meaning you can see it; it's becoming blank. And we could also create roadmaps from our previous runs, or through a current run, where we can actually just sort of freeze the imaging in place and lay out a map of where we need to
Yeah.
go in the brain.
Okay. That's fascinating. That's really helpful. Because it sounds like magic, really, that you can go through your leg or your wrist and get to these places, right?
Yeah,
Are you? I've talked to some of your colleagues who happen to be very fast drivers, because they get called for stroke. Are you rushing to the hospital a lot?
that's correct.
Yeah.
So, there's an old moniker, time is brain.
Yeah.
And so we have to be within 30 minutes of any hospital that we're on call. And these calls can come at any time. So if a patient comes in at 2 in the morning with a new onset symptoms that were witnessed and somebody there, and the patient was fortunate enough to have a family member call the 911 for them, um, emergency medical services or EMS, they would pick that patient up and they would identify where the comprehensive stroke centers are based on the symptoms that they have. And they do a really good job of identifying patients who are potential stroke patients and funneling them to the centers that can actually offer this advanced treatment.
The EMS folks are good at
Yes,
saying, okay, so you get the call and then you dash off.
exactly. So we have a whole team, so it's not a lone effort. We have emergency medicine physicians who lay the initial eyes on these patients, stabilize them if there's any other medical issues that need to be sort of addressed before they can go to an intervention. And then in addition to that, we have nurses in the IR suite and technologists who not only are
The
familiar.
IR suite is the
Interventional radiology suite.
okay.
Yeah, so those are the rooms that are equipped with our imaging tools to be able to look at our devices and the blood vessels.
Okay. Okay. And that's interventionalist because you're using radiology not just to look at something, but to go inside
Exactly,
and do things. Okay.
exactly,
Okay. So again, you're one of these surgeons who has to rush to the hospital, get time is brain, get this done as quickly as you can.
correct. Yeah. Yeah, so because we are minimally invasive though, I think that affords us the ability to intervene quickly in a way because we don't have to cut through the brain. We don't have to prep everything like super. I mean, we do prep patients to kind of a sterile field around
Sure.
wherever we puncture, but we don't need to, kind of shave the head and, create a super sterile
Mm.
room with so that we can start drilling through the skull and potentially so those are things that kinda limit the ability of a lot of the more invasive surgeries.
Are those still going on?
Yes.
They are.
Yeah, so, we are just one tool in the armamentarium of neurovascular disease,
Yeah.
and we work closely with neurosurgeons to, provide patients with what is the best treatment for them, and there are many instances in which open surgery is the best treatment and most definitive treatment.
Hmm.
And a good example of that would be something like an arteriovenous malformation. These are when arteries connect directly to the veins and they engorge the veins and eventually the veins rupture. So
And that can happen
in the brain.
in the brain.
Exactly. And so in those particular diseases, we have studied those closely and found that treating them endovascularly is not sufficient, and very often there's a recurrence that occurs down the road. So what we will typically do as neurointerventionists is not only characterize them through angiography, which has the highest resolution and the most dynamic
Characterize, I mean
resolution.
describe,
Yeah, to be able to
map.
like map it out, find
Mhm.
out which arteries are feeding into it, how is it draining out? Is there something like an aneurysm within that whole mishmash network of blood vessels? Because it tends to look like a spaghetti mess.
Is this something that you're born with that just becomes bad over time, or is it something that forms?
That's a great question. I think for the most part, we probably think people are born with them.
Okay.
But
Arteries connected to veins.
yeah,
And that's not good because
abnormally.
arteries are going one way and veins are going the other, right? Or is that
Correct. So usually what happens is that arteries do connect to veins, but they do so through a network that is at a single cell level.
yeah,
So
tiny capillary.
exactly,
Yeah.
capillaries and venules, and it allows passage of one red blood cell at a
Yeah.
time.
Not
A
a
whole jet
highway of,
stream, exactly, of
but that
blood
happens.
that
And you
happens.
can live with that for a while.
People they can develop, kind of like non-specific symptoms like cognitive issues. They can also
Hmm.
develop seizures,
Hmm.
and they could also develop, ruptures. So that means that the veins will typically burst
Hmm.
or the arteries will have an aneurysm that bursts, and that can cause massive brain bleed and cause neurologic deficits.
So the reason you have to go in there is this is a more of a plumbing problem than you can do with these tiny instruments.
No, there's a pretty good body of evidence of people doing it in Europe, almost achieving what we would call like cures. but the recurrence rates are somewhat high. So you can treat it so that at the end of your procedure, it looks like that that lesion, that arteriovenous malformation, is completely disappeared. But then you come back, a year later, and you find that there is a new connection somewhere.
Mm,
And so we've identified through clinical research worldwide, right, that surgery is the most definitive option with the lowest recurrence rates.
okay. Okay.
So we will often aid the surgeons by either blocking the blood flow to a principal feeder that can lead to intraoperative complications such as
Yeah.
bleeding, or if there's like an aneurysm within that malformation that needs to be treated and prevent the risk of recurrent bleeding. But that's how we contribute to that care. But
Sure.
again, just sort of speaking volumes about our neurosurgical counterparts that use open methods are still very important in managing neurovascular
Okay.
disease.
Okay. All right. But yeah, but with if you can go minimally invasive for the reasons we just described.
Correct.
Yeah.
I think a lot of patients, if there's a chance that you can get them through and eliminate the risk of an imminent brain bleed or recurrent stroke, most would prefer a less
Sure.
invasive option over a more
Yeah.
invasive option.
So are you good under pressure?
Yeah, I think that's part of the job description for sure. I think that everybody operates under pressure in these environments and situations. That's I think kind of has to go back to the teamwork that's involved with this, having good communication skills with your team, expectations, and them knowing that they can rely on you as well to communicate what
Mm,
you need. Um, there's no room for egos or temper tantrums there. We have to
I
do what's
bet.
best for the patients, and we have to make sure that we're working in a very productive, constructive way.
Are you just? I mean, do you have any tactics for like get called in the middle of the night, gotta run into the hospital and do this in you know
As soon as possible.
yeah. I mean
Well, they've been
that's
trained, right? So that's kind of part of what we build as a comprehensive stroke
yeah.
program is the expectation of like when they're going to be on call, what's required when you're on call, what are the timelines that we have to intervene within to meet our metrics, which have been associated with better outcomes.
Hmm.
And so they know they have to be in the hospital within 30 minutes. So, when somebody's signing that contract with the hospital, they have to make sure that they can live up to that expectation.
Oh my gosh, yeah.
Um, but we, know what we need. They know what kind of instruments we're frequently using. And so most of the techs working in neurovascular tend to have a little bit more experience than the standard radiology tech, given the specialized expertise needed to, sort of facilitate this sort of care in
Yeah.
a time sensitive manner.
Yeah. No, I mean it's got to be exhilarating at times.
Exhilarating, stressful,
Yeah.
sometimes, you don't know how it's going to go. Um, there's always a risk of a complication, which is what we strive to minimize and eliminate. But when you're dealing with the high acuity situations like these, there's always a small risk that you could end up causing more harm than good. And so
Mm,
that kind of keeps you on your toes, and you got to
sure.
make sure that you disclose that information to a family member before you do the intervention so they know what to expect. So in acute ischemic stroke, the complication rates have been estimated to be anywhere from 7% to about 15%.
Okay.
That's the treatment can be complicated by that much. But if we're successful in getting the blood vessel open without a complication, we
Yeah.
can restore the function of these patients who are severely impaired up to 50% of the time. So it's a calculated
Yeah.
risk.
That's yeah, totally. And it's yeah, those numbers say why you do it, right?
Exactly.
Yeah. Imaging is becoming more and more uh powerful,
Correct.
right? Are you seeing that leverage in your field and
Absolutely. Yeah. So, we've been using artificial intelligence imaging systems and platforms to not only identify these patients who have acute ischemic strokes, but also basically prognosticate how well they might recover if we are able to intervene in a timely manner and get it open. I think this kind of brings a lot of um, sort of knowledge to the table up front
Hmm.
before you're doing the intervention, as opposed to going into completely blind and agnostic.
Mm. Okay, so tell me about how AI might you mentioned AI. How might that where does that come in when into a case?
Yeah, very often it's the first imaging that the patient will get when they arrive to the hospital.
So somebody's come to the hospital, they've got clearly having a stroke, or maybe not so clearly,
They'll go
but
to a computed tomography scan or a CT scan
okay.
and get an IV access to inject iodinated contrast,
So you can
and
see it.
so you can see what's going on in the
Yep.
blood vessels. And these algorithms will not only identify where the blockage is, but how much brain tissue has died, how much brain tissue has not died, but is at risk of dying if we do nothing.
The algorithms are doing that?
Yeah, and they spit that out within 15 minutes typically.
So they're looking at the images, CT images, and it's like AI. So I've seen how fast it works on other things.
Correct.
It's looking at this and spitting out how does the information come to you?
So it usually
Is
comes
it
to
like
me
a
as a color coded map.
okay,
So,
okay.
so I'll see green where there's tissue that's at risk of dying, and I'll see either, another color if there's tissue that's already been totally done with.
Wow.
And so we can tell the family members before we even do the intervention
What
almost like what to expect in terms of recovery if we intervene and we're successful.
how long have you had that capability?
So that all came out in about 2018 as it became clinically validated. That was a trial that was trying to extend the treatment time window for these large vessel occlusion strokes. Our initial trials were conducted in 2015 to show that there was any benefit at all to mechanically opening these blood vessels. But that was within 6 hours of the last known normal. So that would have excluded a lot of patients who would have presented to the hospital.
Wait, say that again. So your study, you mentioned a 2015 study
Was when we first got the okay to start doing this.
doing
Cleaning up blood vessels.
oh, okay, okay.
And then artificial intelligence became incorporated into our workflow in 2018. Uh,
Oh, so you were ahead of the game. I mean,
I think we were.
yeah, I
I
mean,
think that's kind of
everybody
like
else heard about it in, last year.
exactly. So I think that that's one of the fascinating things about our field is that it's kind of on the cutting edge of technology. I
Yeah.
would say neuroscience, clinical neurosciences in general, is just a fascinating field that I think is really poised to grow over the coming decades because of the augmentation of technology, software, hardware, to deliver more precise, personalized solutions for patients with neurologic disease.
How do you think AI has performed so far? Do you have a sense of how good it is at this?
So for acute ischemic stroke detection, it's been pretty good. There's always issues, of course, when the patient moves, right? That can affect some of the parameters that it
Mhm.
uses to materialize its, end result. That said, there's always the need to sort of corroborate what the AI generated results is with what you know as a
Mhm,
practitioner
mhm.
and what's been tried and true.
Mm,
For instance, people who present within 6 hours of their last known normal with an acute ischemic large vessel occlusion stroke, they can get this perfusion imaging. And sometimes that perfusion imaging that's generated from the artificial intelligence platform might misidentify how much permanent damage has been done in those early windows. And
hmm,
that's been shown in a couple studies.
hmm,
So we as practitioners have to kind of take that data that's been demonstrated through clinical series and understand how we can use the artificial intelligence platform to inform what the prognosis is
mm,
and when we can kind of not necessarily discard the information, but hopefully be able to discern, what might still be not completely sussed out just from the AI generated
sure.
results.
Do you find that AI over or underestimates damage, or is that a fair question?
Um, I don't know the exact statistics, to be honest with you. I think that there is a tendency at times to underestimate, and there's a tendency to overestimate.
It's probably it's tuning, probably.
Exactly. So there's, these are the early stages, right?
Yeah.
And a lot of the software, because they got early clinical approval, I think naturally they've been a little bit slower to modify and improve upon the processes because once you have FDA approval,
Oh,
right, limits how you can iterate.
is that right?
Yes. So the FDA
Brings it to a
monitors
back.
exactly. You have to resubmit
Yeah,
any
yeah.
improvements. Now there's some exceptions there for software compared to hardware,
One
but
would hope.
it would be kind of interesting to know how much of that has been a factor
Yeah.
and
That's a good study.
refining
Yeah,
these imaging tools.
right. Because technology moves at a pace that probably exceeds the FDA
Exactly.
regulators. I mean, that's always true, but
In this case, for sure.
in this case, it's also critical. I
Exactly.
mean, right, in all of this.
But again, a lot of the decision making that we make, we can use a lot of clinical data and information. So if I know that a family member has seen this patient well within 24 hours, there's almost no reason not to open up the blood vessel.
Oh, yeah.
Okay.
Right. Uh, so take the opposite of that. When would you not? Because it's just the person is, I mean, sorry to say, but too far gone?
So it used to be that way. And I would say that we're now headed towards a kind of a brand new frontier or bold frontier in our practice. There's been a few randomized trials conducted looking at these large core infarcts, which are
What are those?
these are basically strokes that have almost completely caused all the damage that they would have caused at any point. So, we're typically intervening on the cases that have a fair amount of mismatch between the tissue that's already dead and the amount of tissue that looks viable in these perfusion
Mm,
imaging modalities. But now there's no new data to suggest that even when it looks like all the brain tissue is already dead, that there still might be some benefit
some
to opening up the blood vessel
okay. Two terms there. Large core. Are we talking like just the size of
of the damage,
the damage?
the permanent
Okay.
damage.
And when you say perfusion mapping, are we talking about
Blood flow
blood?
dynamic.
Okay, got it. That's what I
Exactly.
figured. Okay. So the upshot is you're probably intervening more even when it looks bad. Is that right?
I think that that's where the field is headed right now. So there's a lot of swelling that occurs when there's brain tissue damage,
Yeah.
and some of that brain tissue damage swelling obscures where there's possibly some little islands of
Mm,
viable brain tissue.
mm,
And so what we're learning is that despite how bad the picture looks,
mm.
people do recover more function even if it looks completely
Really
far
bad.
gone. They recover more function by getting our intervention than not. And so that's something that's actually come out over the last couple of years in terms of randomized trials.
Have we have you as a specialty uh, been surprised by the powers of neuroplasticity? I mean, I hear that term a lot in
Right.
different areas that, people are like, well, the brain, it actually can adapt really well. If it loses this sense, fall back on this sense and find a hack.
Yeah.
Right. And my friend who was on the bumper cars and, it damaged his, one of his artery. Yeah. And stopped blood flow for a while. He had to relearn how to speak, but he did it because his brain rewired around the part that was damaged and he's able to speak.
Right.
I mean, it seems like I remember when I was younger, I thought the brain was a brain. It was done. It wasn't going to evolve. It wasn't going to change anymore. And now we're talking about neuroplasticity.
Correct. Yeah. So I think that's a great segue into what I think is the most exciting part of stroke neurology or stroke
Mm,
rehabilitation now. But in addition to all that, I just addressed that specifically. There was an old dogma that suggested that, you would recover from a stroke up to a year out from the stroke. But I think there's a lot of science now that's challenging that
you
assumption.
mean after a year, that's where you're going to be?
Yeah. So
Okay.
I think that you generally do plateau and the improvements become more incremental.
Hmm.
But just like, your grandmother can still learn how to use an iPhone after you give it to her. It's just an example
Yeah,
of the
it
brain
could
being
be.
able
Yeah,
to adapt.
good example.
So that's exactly, I think, the same sort of paradigm that you have to extend to people with stroke recovery
Yeah.
is that there is probably not as robust of a way to make new connections because you are an adult-sized brain, you're not growing
Hmm.
per se, but there are different mechanisms for neurons to connect with each other and bypass damaged areas to create a function that was not previously their function to carry in order to enable some sort of recuperation of these damaged functionalities.
I mean, that's encouraging, right? Right.
Yeah, and then
Yeah.
on the, I guess, downstream of all that, when you get into, some of these hot topics like neural interfaces, there are indeed a couple of companies, one of them called Neurolutions that got, FDA approval recently. It's a platform that has shown to, improve upper extremity rehabilitation over standard rehabilitation. It uses stimulation of the brain and
Mechanical,
or
electrical.
yeah, I think actually this one actually only uses recordings of the brain and tries to um, it, I guess let me take that back. It is using the signals from the brain to enable you to use a prosthetic arm to regain some upper
Wow.
extremity function.
Wow.
There's another device that is been used traditionally for Parkinson's disease. That's called deep brain stimulation.
Yeah. Yeah.
And so there's been some early clinical evidence to suggest that if you were to do one of these deep brain stimulators, one of the small areas of the brain near the back called the cerebellum, that can lead to more robust recovery of lost function.
Yeah. And so you're augmenting the plasticity.
Exactly. That's the thought.
That's the thought, right?
And
Maybe.
so right now, I would say that the basic sort of understanding of these mechanisms is still sort of lagging behind what we see
Mm.
empirically, which is that these patients are improving.
Have you been surprised with at a case where you think, oh my gosh, this is really bad, and then the person is actually
Yeah.
done pretty darn well?
Yes. I think it's always actually kind of paradoxical sometimes. I've had patients come out of a successful procedure that looks like everything is still relatively intact with very minimal damage, and they might have a very prolonged recovery. I've had other patients who have like a lot of damage, at least imaging wise, and somehow make a much brisker recovery.
Hmm.
And so I think that speaks a little bit to the individual variation that we have within our species. Our wiring is not totally stereotyped across every individual, right? In the same way that like our faces are not and our heights are not. There's
No.
differences between us, and that difference is something that we haven't really been able to capture at a granular level and help inform prognosis. But ideally, as we sort of enter into this more sophisticated digital and technology age, we might be able to better identify patients who are going to be responders to
Hmm.
certain therapies and how prognosticate their eventual neurologic outcome.
How often do you see patients in non-emergency situations where you see that they have a problem, and you're like, "Hey, we should really keep an eye on this." And
Absolutely.
how does that arise?
Yeah. So usually it's because a person might have had like a temporary set of symptoms that got better, but underwent the imaging anyways, that would have looked and seen if there was anything wrong with the blood vessels. That often happens with aneurysms. So people will come in with headaches.
Mm.
They'll get brain imaging, and then that brain imaging will reveal an aneurysm that hasn't ruptured. And that is a way that people might come to our office and say, like, look, I've had this imaging finding. What do we do about this? Uh, Oftentimes with aneurysms, right, if they're small and kind of innocuous looking, we can watch them and see if they grow
Hmm.
or change in shape.
Hmm.
And
'Cause
that
that's a bulge, right? An
it's a
aneurysm's
bulge, exactly.
yeah.
An aneurysm's kind of like I like to describe it a little bit as like a hernia of the
Mhm,
artery.
mhm.
So wherever there's sort of a weakening in the wall, it starts to bulge out there, and that wall is much thinner than the rest of
Yeah.
the wall of the arteries. And so over time, that bulge can grow and eventually burst. And when it does, it can be catastrophic for patients.
And that's just I mean, that can happen to anybody, right? I mean, this is just
Exactly. So it's rare, I would say overall, but still pretty common
oh,
in
yeah.
terms of
Most yeah.
neurovascular diseases that are diagnosed. And I think that from our perspective, we try to do whatever we can to like identify patients who are low risk of rupture that can tolerate just surveillance imaging
Yeah,
to reassure them that there's no need for intervention. And then out of those patients as well, see which ones might need an intervention sooner than later.
yeah. Is there anything we can do as, you know, consumers and of healthcare to avoid having to see you?
Yeah. So
Lifestyle?
yeah, lifestyle is a big part of it. I think that there's a lot of attention now being played to microplastics.
Oh, Lord.
So we're finding, obviously a lot of the packaging that we're using in our food gets embedded within, you know, our nutrition, our daily nutrition. I've heard it said once that on average Americans consume the equivalent of a credit card in plastic a week.
Are you kidding me?
I'm not sure about that, but
Oh
that's
my
what I've
gosh.
heard. And that's just sort of an anecdote, so I'm saying it from hearsay. But
Yeah, yeah, no, certainly. Well, we can
but
yeah.
the whole idea there is that these microplastics, any foreign material within the body, causes inflammation, and that can
Mhm.
lead to vascular disease can cause to early cancer, right? So we're seeing the rise of cancer as well
Yeah.
everywhere. So there's
Gastric
that element.
cancer, or I mean, intestinal cancer, like young
Gastrointestinal
people.
cancer, colon cancer, exactly. The in addition to all that, right, we have this highly processed or ultra processed foods that are
Yeah.
um, no good. And I would say to anybody who wants to avoid any sort of vascular disease or cancer in general, which is, I think, kind of all stemming from the same problems, right, which is the lack of activity,
Mm,
um, sort of ultra processed foods, and a lot of the contaminants in our environment.
yeah.
And so,
Yeah.
avoiding those things as much as possible and keeping your activity levels up can stave off a stroke. It is said that generally 80% of strokes can be reduced or eliminated with the right lifestyle changes. So,
Okay.
daily exercising, eating the right
Yeah.
things, and most importantly, actually, is good social connections.
Yeah.
So, emotional well-being
Mm,
is a huge role in basically decreasing the inflammation in your body. And
that's amazing.
and I think that's just an amazing
Yeah.
thing that we've sort of just tipped the iceberg on, but I
Yeah.
think ultimately we're gonna see that people who are better, connected socially have, more emotional well-being in many instances, and those are the individuals that, have paradoxes that despite having maybe certain dietary or lifestyle risk for stroke or vascular disease, don't develop them as frequently as people who are living in isolation or, um
Hanging out with your friends might actually decrease inflammation.
Yeah, there's they say that men who have like a like more than one person that they keep in contact with tend to live longer than men who don't.
That's interesting. That's really, yeah. I've heard similar things. Yeah, that's terrific. Wow. Um, Dr. Morales, this is great. I really appreciate this. I think, as I say, we've heard some descriptions of these mechanisms that are really helpful and illustrative.
Thank you.
So thanks for coming in and doing
That's been my
that.
pleasure.
Yeah, we'll do it again.
Thank you.